land acknowledgement this morning after some reflection on our past acknowledgements at this forum, which have included donations to the Native Women's Resource Centre of Toronto, statements from the Truth and Reconciliation Report, and the U of T land acknowledgement. By way of a desire for greater change, this morning we will share the link to the Chani Wenjack story, as brought to light by Gordon Downey via his Secret Path project. The link will be posted in the chat box for you to consider later. We have a special session today. Dr. Rebecca Nuttall, PGY4 Geriatric Medicine Subspecialty Resident, will lead us off with the short presentation of a cohort study illuminating the comparative effectiveness of 3 newer oral hypoglycemic agents using big data. We then have the long presentation, which will be delivered by one of our aspiring clinician scientists and former lead resident, Dr. Christina Reppas. I will introduce Christina before her presentation. So Rebecca, please feel free to share your slides and start. Are you having trouble?
Yes, I have to change my settings, so I apologize. I haven't. It's a new laptop.
No problem.
It's saying I have to quit and reopen. I'll be right back, everyone. My apologies.
Liz?
Yes.
The copy that I have of Rebecca's slides, the link is inactive. I wonder if you have these slides.
Yes. Let me
if Rebecca's not able to do it, we can share them with the group. There we go.
Okay.
Perfect.
So, ready?
Great.
Okay. So, good morning, everyone. It's good to meet you all virtually. The article I'll be appraising today is from JAMA, and Dr. Gandel just introduced the title of it. I have nothing to disclose. So it's going to be a typical presentation, except I added an extra section to the critical appraisal part, focusing on the statistical analysis, because this is more of a special journal club day. So I want all of you guys to imagine you have an 85-year-old female, and she's 5 and a 9 on the clinical frailty scale. She has type 2 diabetes, obesity, hypertension, and dyslipidemia, and she's on her max dose of metformin, and she's not at target, unfortunately. So which would you like to start out of these 4 anti-hyperglycemic groups? So we have Empagliflozin, Liraglutide, Sitagliptinin, and glycoside. So the current Diabetes Canada guidelines recommend DPP-4 inhibitors as second line to metformin in older adults, and this is largely because of the robust evidence for their safety and efficacy in older persons. As an aside, and this is I found interesting to learn, I didn't know it myself, you may consider DPP-4s as first line if the older person is lean, because the pathophysiology of their diabetes is likely due to an impaired insulin secretion, and metformin may contribute to reduced muscle mass. But that was just an aside. Guidelines state that you should consider either empagliflozin or liraglutide after DPP-4s to achieve target A1C in cardiovascular disease. They also should have no complex comorbidities, which I'm assuming means frailty, but it's unclear when you're reading the guidelines. And their eGFR should be greater than 30, albeit empagliflozin is now safe in eGFRs greater than 20. They just haven't updated the guidelines. And both the GLP-1s and the SGLT2s, in terms of adding them as third-line therapy, are grade A class 1C evidence. So they don't really distinguish between the two. And then with respect to empagliflozin side effects, there's probably an increased risk of dehydration and fractures in the elderly with a similar rate of GU infections as compared to the young, whereas GLP-1s are better tolerated, except for GI side effects, which is across all age groups. So we know that there's an increased risk or CVD risk in older adults with type 2 diabetes. But the study also pointed out that the CV benefits of using SGLT2s and GLP-1s differ by patient subgroup. So for instance, if you look at my first bullet point, in patients with cardiovascular disease and heart failure, both SGLT2s and GLP-1s were shown to reduce major adverse cardiovascular events. And then 2 other studies showed that empagliflozin reduces both CV death and MACE, but only in ages greater than 65. And then another study suggested that liraglutide reduces MACEs more so in patients greater than 75 years old as compared to less than 75 years old. And ultimately, there's limited evidence for direct comparison of empagliflozin with liraglutide in patients who have a broader spectrum of cardiovascular disease or heart failure in high or beaten age groups. So this was a retrospective new user comparative effectiveness cohort study. The population was from claims-based data from Medicare fee-for-service beneficiaries greater than 65. They all had to have type 2 diabetes, and the data was collected from August, or not collected, but the data was from August 2014 to September 2018. So it was over 4 years. The first cohort that they looked at was the first filled prescription of empagliflozin versus liraglutide. The second was Empa versus Sitagliptin. And then the outcomes they looked at, the outcomes that they looked at were modified major adverse cardiovascular events. So their version of MACEs, which were MI, stroke, and all-cause mortality, hospitalization for heart failure, specifically whether or not the diagnosis for heart failure was recorded in the first field. And then secondary outcomes that they looked at were the individual components of the MACE, and then a different placement of the heart failure diagnosis. And just so you guys are all aware, Medicare is the United States Federal Health Copay Insurance Program. I had to learn a little bit about it. So in terms of the exclusion criteria, the things I wanted to really focus on was that they excluded the ESRD, HIV, solid organ transplant, cancer, and then they also excluded nursing home admissions. Everything was collected over a 12-month baseline eligibility period, the exposures and the outcomes, the exposures. And then they were considered exposed until 60 days after last day's supply. And they were followed until drug discontinuation, 30-day gap in Medicare enrollment, death, study, and/or study outcomes. So the authors used propensity score matching to account for measured confounders. They identified 143 covariates using clinical knowledge and literature review, which they didn't really elaborate on in terms of their process. To calculate the propensity scores, they used multivariable logistic regression. For matching, they used the one-to-one nearest neighbor method without replacement. I have a typo. Oh, I fixed it. Where was I? And they used a maximum caliper width of 0.01. And the caliper width defines the range within which the propensity scores must fall to be considered a valid match. So they assessed balance of the match by calculating the absolute standardized mean differences as well as C statistics, but they didn't report the C statistics in the table. They just mentioned it in the discussion. And then to measure treatment effects of the main outcomes, they calculated hazard ratios and absolute rate differences. And to account for the competing risk of death as an outcome, they developed cumulative incidence function plots, which are important in determining disease risk for elderly individuals given their increased risk of death. So they perform multiple sensitivity analyses, To account for potential residual confounding, they restricted the studies to people using metformin at baseline or people not using insulin at baseline. To address a potential strong unmeasured confounder being A1C, they performed a complicated bias analysis. And to address, to address exposure misclassification, they reduced the risk period from 60 to 30 days. And then to account for informative censoring, they performed an ITT analysis for up to 2 years to account for the people that didn't discontinued or switched drugs. Okay. So pre-match, the sample size was 230, post-match, 230,000. Post-match, it was much smaller. It was about 90,000. The characteristics included, the ones that I wanted to point out anyway, included a mean frailty index of 0.2, and they used this validated frailty score using claims-based data that they referenced in the study. It's essentially a 4-point Likert scale, and so the frailty index was between 2 and the mean frailty index was essentially between 2 vulnerable and 3 frail. The mean age is around 72 years old. Everyone was, or not everyone, there was greater than 80% of eligible, or sorry, greater than 80% of the people were white. And then approximately, and there was about a 50-50 male-female ratio, which was great between the 2 cohorts. Balance was calculated to be satisfactory. The median treatment duration was unfortunately only 5 months. And then here's my list of censoring reasons, the majority being from drug discontinuation and the end of the study, and 0% was death. So just briefly looking at the results. So when you're looking at the treatment effect estimates of the major outcomes, empagliflozin was shown to possibly provide a lower risk of hospitalizations for heart failure and MI compared to liraglutide. It may also provide a lower risk of death when compared to sitagliptin, which I found pretty interesting considering both current guidelines and known adverse events of the drug. And then empagliflozin may provide a lower risk of modified MACE and hospitalizations for heart failure across all patient subgroups compared to sitagliptin, as demonstrated in my next slide here. So like I said, this is the subgroup analysis table. And of note, absolute benefits were associated with empagliflozin compared to sitagliptin. Or the absolute benefits were larger in adults 75 years or older versus adults younger than 75 years, which I also found interesting because it reminded me of the liraglutide study I referenced earlier. So bringing our attention to the top box, there was also potential heterogeneity among sexes, indicating that compared to liraglutide, empagliflozin may be associated with a lower risk of MACE, but only in males. And then looking at the bottom 2 highlighted rows, empagliflozin may be preferable to liraglutide with respect to MACE, but only in cardiovascular disease and heart failure. And then finally, on the right of each subgroup analysis table, the rate differences across subgroups within both cohorts indicated that empagliflozin may provide larger absolute benefits in patients with cardiorenal disease. Okay, so getting into the critical appraisal part, were the 2 groups similar and recruited from the same population? So the authors did provide clear inclusion and exclusion criteria. Differences remained and were addressed by propensity score matching, which theoretically increased their similarity. And post-match, there was similar sex and race ethnicity between the 2 cohorts. So were the exposures measured similarly to assign people to both exposed and unexposed groups? Yes. I said partially for was the exposure measured in a valid and reliable way, because there is presumably good reliability as data was based on documented drug dispensary, assuming a reproducible distribution of population characteristics. But the validity was impaired as they didn't measure adherence, only whether the drug was dispensed. They addressed exposure misclassification only by performing a sensitivity analysis on a shorter end of exposure window. And then were confounding factors identified. And I'm going to address 4 and 5 kind of in the same breath here. So we know to deal with measured confounders, they use propensity score matching and sensitivity analyses of metformin and insulin users. But for unmeasured confounders, they chose A1C to perform a bias analysis on only. And they could have considered functional status as another relevant strong unmeasured confounder. And then in terms of the strategies to deal with it, I kind of alluded to it already, but they didn't specifically get into the weeds there. They just said that it was from like expertise and literature review, and they could have made it more and if you look at the supplementary slide, it was quite comprehensive, but they could have possibly added machine learning, for example, or like used a couple more methods of covariate identification. It seemed a bit arbitrary to me. And then I said unclear for were the group's participants free of the outcome at the start of the study, because they didn't comment on Medicare's role within the greater system or how comprehensive it is per client. So it left it difficult to comment on any potential bias, including accuracy of the database. And like, for example, did any patients experience a study outcome within the 12-month exclusion period not claimed within Medicare? Or I guess in other words, if a patient is insured by Medicare, does that mean all outcomes will be captured by a claim? So I said partially were the outcomes measured in a valid and reliable way, because there was good inter-rater reliability, presumably, and reasonable validity, because they used Medicare claims-based algorithms from previous validation studies, which had high specificity and a high positive predictive value. But I suspect sensitivity and thus validity were mildly impaired as they only captured inpatient data. So, for example, they may have had a stroke or MI out of hospital, survived, and did not seek medical attention, although this is obviously less likely to occur. And on a positive note, they did account for the competing risk of death by using the cumulative incidence plots. So I said no to was follow-up time adequate. It was 2 years was the goal, so that even the goal I felt was not adequate. And it was a retrospective cohort study. I mean, I know we're limited because they're relatively new drugs, but I would have liked to see a longer follow-up period. And then ultimately this ended up being leaving everyone with a median exposure period of 5 months. So in terms of 9, the authors could have improved follow-up analysis with their ITT analysis by characterizing reasoning, or in addition to the ITT analysis, by characterizing the reasoning for discontinuing the drug switch with subsequent interpretation. So it's hard to say that the ITT analysis, or it's hard to make use of the ITT analysis when we don't actually know the reasons for why they discontinued the drug, because it assumes that the reasons aren't relevant to the study outcome. And then I kind of already addressed this. So they use the ITT analysis. And then for number 11, so they use propensity score matching, as you guys are aware. And it was actually a reasonable choice, even though it's less used these days, because it's good for large sample sizes. And this was quite a large sample size. It does truncate eligible participants, possibly biasing the results. And inverse probability weighting, which is another propensity score method, for instance, would have included all of the eligible participants, but it would have probably confounded the outcomes by extreme weighting of the eligible participants. Okay. So were the confounders, sorry, my apologies. I'm very technologically challenged. So in terms of the confounders being identified in a valid and reliable way, I've already touched on that. My apologies. Okay, so for number 13, was the PS matching algorithm, distance metric, and matching ratio explicitly stated? Yes, I've already told you guys what those were. Was it indicated whether sampling used replacement? Yes, they didn't use replacement, but that was reasonable because the balance of the match was satisfactory. And then they did explain the statistical they did explain the methods, and they did appropriately assess balance. Usually you shouldn't typically use C or P statistics because it's kind of an internal sample, and it exaggerates the balance. So the absolute standardized mean differences is more appropriate, which is what they used. And then for number 17, they unfortunately didn't break down the composition of the propensity scores, and it would have been interesting to see how they were developed. So what factors contributed to the propensity, or what patient characteristics contributed to the propensity scores. And then they didn't address the missing data at all, unfortunately. They briefly mentioned it. They didn't suggest any strategies to account for it. And then in terms of whether or not the results were generalizable, I did feel that obviously it was only useful for a certain level of frailty, a certain race and ethnicity. And so unfortunately, we can't obviously assume it's for our diverse population that we serve here in Toronto. So, again, my apologies. Okay, so back to the case. We have an 85-year-old female, all of the same features, and I'm just wondering, which one would you now choose? For me, I would choose, initially when I first started, I was thinking, well, maybe I would want to choose empagliflozin or the GLP-1 inhibitor to improve their cardiovascular risk. But now, knowing everything that I know, she doesn't meet the criteria for the cardiorenal disease, established cardiorenal disease. She just has the risk factors. So I would ultimately choose, and also DPP-4 is technically second line still, before even adding on the other two. And so that's why I would choose a DPP-4 inhibitor now. And then ultimately, we discussed that the study has limited generalizability. We should still continue to consider the patient subgroup. Obviously, we actually kind of reproduced some of the results other studies had shown. And then we should always caution regarding adverse events in the frail elderly, especially with SGLT2s. But what I found interesting from this study is that keeping generalizability in mind, race and ethnicity and frailty, while remaining cautious of adverse events, you could consider an SGLT2 over a DPP-4 as second line for mortality benefit in patients with cardiorenal disease and similar disease profiles. So that is the end of my presentation. I'm open to all discussions, and I am very sorry for the technological challenges.
Thank you very much, Rebecca. Beautiful presentation, particularly with so many data points. You did very well to isolate and clearly explain the outcome. So thank you very much. Christina, would you like to, and Rebecca, would you like to take a few questions now, or would the questions be better served after the second portion of this presentation?
Either one. I'm just worried that maybe there'll be less questions for Rebecca afterwards. I don't,
okay.
Doesn't matter, but yeah.
So go ahead, questions for Rebecca. In the chat box.
Thought Michael had his hand up.
Oh, I'm sorry, Michael, I didn't see. Go ahead.
I
Thanks,
just
Carol.
have one question, probably an outcome of my years on the DQTC, and this is, of course, American. Is there any cost-benefit analysis? Because clearly, if one of the drugs was much more expensive or less expensive than the other, that might shift prescribing, propulsion. They're both new drugs. I suspect they're both relatively expensive, and compared to the other drugs, they're much more expensive. Obviously, sulfonylureas cost nothing these days, and probably that's what they're worth in this population. But was anything done in the Medicare database on this?
So they excluded Medicare C. Now, this is me like inferring because I tried to learn about the Medicare system. And Medicare C includes private healthcare bundles. So they did kind of remove a group of people that seemingly have more money to spend. So that was the only kind of way that they addressed that. And then it's possible that because I don't have all the baseline characteristics memorized, it is possible that it was included in the propensity score matching to account for it, but I'd have to pull it up and look for it in the massive table. But I would look in the table of all the baseline match characteristics in the supplementary tables. They have like all the characteristics, and then I would look at the post-match characteristics, and then so they might have accounted for it.
Thank you. Any other questions for Rebecca?
I have a quick question, Rebecca.
Go ahead.
It relates to the high rate of treatment discontinuation. So you said that like 50% of the group almost, and I think it was across all drugs, almost 50% stopped the drug due to treatment discontinuation. I wonder if you can sort of just comment on whether you think that is just an example of like real world data, or is that something that strikes you as a bit unusual, and how might that have affected some of their analyses related to the outcome?
Yeah. So I think that this was an issue with respect to the follow-up analysis, because I would have loved to have seen the breakdown of why the drug was discontinued. Because if the drug was discontinued due to a side effect, that would be one thing. If it was discontinued due to an adverse event, that would be another thing. Or if it was just from a prescriber wanting to deprescribe because they were thinking, oh, this isn't safe in the elderly population, let's just stop it. So those are just some reasons that I'm thinking of off the top of my head that would have contributed to this. So I do believe it was probably representative of the real world, and therefore it would have been nice to see the reasoning behind the drug discontinuation to see if it was actually reasonable to perform ITT analysis that way.
Thank you. And perhaps I can offer one last question before we move on to the second. Do you know if there's any randomized data comparing these drugs, and do you think that that will ever come?
I don't know if there's any randomized data comparing these drugs. I'm trying to think back to the studies I just recently referenced, but I believe that they were all retrospective. Some of them are retrospective. The issue is there's no randomized controlled trials for the elderly. I know that, except for DPP4s, or I'm not sure if there are RCTs with DPP4s, but the evidence is robust, and it is not with GLP4s and SGLT2s. I do think they will come. There is a trend towards using them. But I think that the very, very, very frail will probably never be included.
Great. Thank you very much. So we will move on to our second presentation. And by way of introduction, Dr. Christina Reppas is a recent graduate from our geriatric medicine program and is now a geriatrician at UHN Sinai, finishing her PhD in clinical epidemiology at the University of Toronto. She is supervised by Dr. Paula Rochon and is supported by a Vanier Canada Graduate Scholarship and the Department of Medicine's Clinician Scientist Training Program. The focus of her PhD research is on using large administrative databases to study how language and immigrant status affect the management of geriatric syndromes such as delirium. Many of you are familiar with just how great Dr. Reppas truly is, and we are very grateful and fortunate to have her present this morning at Journal Club. Christina, over to you.
Thank you, Dr. Kendall, for that very kind introduction. Thank you for the invite. So the focus of my presentation is going to be a little bit different. I'm not going to be critically appraising one study, but I'm going to be talking about understanding observational methods and specifically observational studies using big data, since that's what my PhD is centered on, and talking about some promises and limitations and things to think about from a critical appraisal standpoint. So I don't have any disclosures, and I do receive some salary support from CIHR. Here are our learning objectives for today. So first, I'd like us to better understand observational studies' strengths and limitations after this presentation, as well as to understand how to better critically appraise observational studies that use big data, specifically thinking about sources of bias. And then I am just going to quickly review some key points regarding propensity score methods. And this is only because they are becoming an increasingly popular method for analyzing big data. And I have noticed that over the summer in particular, we've had a number of studies in our journal club that use these methods. Okay, so before going any further, I just want to present some test your knowledge questions, and I'd like you to just think about these, and we're going to answer them together at the end. So question number one is, which of the following systematic biases in observational studies is most difficult to address through statistical analysis? Is it A, information bias, B, selection bias, C, confounding bias, or D, misclassification bias? Okay, question number two, which of the following is true about propensity score methods? A, they reduce confounding by randomly allocating individuals into treated and untreated groups. B, they balance both measured and unmeasured confounders. C, they can analyze data when substantial differences exist in baseline covariates. Or D, they mimic RCTs by separating the study design from the analysis. Okay, so we will come back to these questions at the end. Okay, I thought I'd start with a definition. And the definition I chose for observational studies is an investigation in which the objective is to elucidate cause and effect relationships where it is not feasible to use controlled experimentation. And Bill Cochrane said this in 1965. There were many definitions to choose from, and the reason I chose this one is just to highlight the fact that observational studies still have the same intent often as a randomized trial. The intent is still to estimate a cause and effect relationship. I think it's really important to remember that when we do our critical appraisal, because there are sources of bias that we really need to consider when we're thinking about something as strong as a cause and effect relationship. I also wanted to highlight, just to remind everybody, that observational studies are, of course, below RCTs in terms of quality, in terms of our hierarchy of evidence. But of course, a well-done observational study can still be very impactful. Okay, so here are some previous headlines from observational studies, and I thought I'd kick off some of the limitations by talking about some ways in which they've led us astray in the past. So the first one is hormone replacement therapy in postmenopausal women prevents cardiovascular events. So there were a number of observational studies in the 90s, in the 80s and 90s that showed this. And it wasn't until a clinical trial was done, the Women's Health Initiative, and there's some controversy actually about this trial, but anyways, the point was that they did not see the same benefits for preventing cardiovascular events. In fact, there was some small potential increase in risk. And the discrepancies between the observational studies and the RCTs were largely related to differences in the time since menopause. So the people that ended up in the clinical trial were 10 years out from menopause for the most part, compared to the observational studies that had a much healthier group of participants. The second headline is antioxidant beta-carotene prevents lung cancer. There were many antioxidant kind of observational studies that showed benefit in cancers. And it wasn't until a clinical trial was done, this was published in the New England Journal of Medicine, where they looked at people that were high risk of developing lung cancers. They looked at smokers and actually found that beta-carotene increased the risk of lung cancer. So a very concerning reversal of effect. And then finally, NSAIDs are protective for Alzheimer's disease. So there was a number of observational studies that were done and as well as a systematic review of observational studies, which was published in BMJ, that essentially showed they were protective. And it wasn't until several clinical trials were done that I think this has kind of pretty much been debunked at this point. The last clinical trial that was done was in 2019 by a group in Montreal that showed that there was no evidence for efficacy for NSAIDs in people who were already at high risk for Alzheimer's disease. Okay, so I guess the question you might be thinking now is, observational studies have clearly led us astray. That's not good. And in fact, the father of evidence-based medicine, Dr. David Sackett, once said the same thing. So he said, if you find that a study was not randomized, we'd suggest that you stop reading it and go on to the next article, which is a pretty strong critique. But I'd like us to move on to some of the positives now, and I'd like to try to convince you that they're certainly necessary. And they're probably necessary for three main reasons. The first is that this is kind of an obvious one, but an important one. Not all interventions, especially if they're harmful risk factors, can and should be subjected to experimental investigation. So for example, air pollution, that's not something that we would do a trial about. The second is that they're important and useful for hypothesis generation. And then in fact, Dr. Gandel just asked in our last study, whether it's a clinical trial that's going to come out with a head-to-head comparison of those drugs. And maybe that's important given what this observational study just showed. And thirdly, and probably most importantly, is that especially when it comes to pharmacoepidemiology or drug trials, observational studies evaluate the effective interventions in real-world settings. Randomized control trials often have restrictive inclusion criteria. They have highly selected subjects, and our frail populations or sort of real-world issues related to adherence and drug switching, like happened in this past study, often need observational studies to show some of the real-world data and analysis, and that's really important. So that's why they're necessary, but there are many challenges. And I think the first challenge, especially with regards to big data studies, is the potential for bias. So bias. I said it 3 times because it's really important. We're going to be focusing on it. The other issue with observational studies using big data is multiple testing. And I'll get into that later. And then thirdly, the design of the study is often intertwined with the analysis, which can be concerning. Okay, so the 3 major sources of bias are selection bias, information bias, and confounding bias. And we will go through each of these in turn. And I just wanted to remind everybody that bias is different than random error or noise, right? So noise you can address by increasing sample size. Bias, it doesn't matter how much you increase the sample size, if there is a fixed and reproducible shift related to the true value being away, or say the estimated value being away from the true value, it doesn't matter how much you increase your sample size, that bias will still exist. Okay, so we're going to start with selection bias. That's a pretty important one. And selection bias is defined as distortion from procedures used to select the subjects or from factors that influence study participation. And a good example of this actually comes from the HRT study that I talked about. So it's when factors related to the selection of subjects are related to both the exposure and the outcome. So for example, nurses who are generally more health conscious are probably have an increased tendency to participate in studies. And if they're more health conscious, they might also be more likely to take HRT. And if they're more health conscious, they might be less likely to have bad outcomes. So the association that you see between HRT and disease in that group of healthy nurses is going to be potentially different compared to everybody who is considering HRT perimenopausally. And that is an important sort of selection bias factor that cannot really be analyzed away. In fact, most selection biases cannot be analyzed away. So that's why it's so important to think about it from a study design perspective. I'm going to touch on other sources of selection bias that are common in studies of big data. The first one I just talked about, so I'll just move to number 2. Number 2 is something called survival bias. And that is a bias that results from people entering into a cohort at a certain period of time, but then until getting the exposure, they need to survive for a period of time before getting the exposure. So a good example of this is people that present to the emergency department with an MI need to survive in order to receive cardiac catheterization. So if we did an observational study of cardiac catheterization in everybody presenting to hospital with MI, those that end up getting cardiac catheterization first need to survive from admission to treatment. And so even if you control for patient severity, you can't really eliminate that important bias. So that's important, especially when you're thinking of big data studies that involve interventions that occur during hospital. The other important selection bias example is something called immortal time bias, which is slightly different from survival bias, and essentially it occurs when the entry into the cohort has to depend on a period of survival. So a good example of this is just shown in the Kaplan-Meier curve below. So you can see that from this Kaplan-Meier curve, so this is a study where they looked at people who were treated in a multidisciplinary clinic for chronic kidney disease. So in order to get into the cohort, in order to get into the clinic, they had to have a certain amount of creatinine, and then they were referred. But the people that, so the people that were referred to clinic did very well if they made it to clinic, but there is a gap like right away, you can see in the Kaplan-Meier curve, and that's always a bit concerning. Anytime you see that, you should be wary, because essentially those who never went to clinic were labeled as no multidisciplinary care, but the patients needed to survive to the first clinic visit in order to make it into multidisciplinary care. So that's an example of immortal time bias that really skews the results towards making multidisciplinary care look better. Some examples from today's study, and I know that Rebecca already touched on some of these, but one of them is incidence prevalence bias, which actually the study did a really good job of addressing in their design. So what they had a new user design, which is important because if you look at people, let's say, who've been on the medication for 1 year, you're already selecting for people that are more likely to tolerate the drug. So that is important that they chose a new user design rather than just looking at a random period of time and looking at everybody on that drug during that random period of time, or at everybody that was on the drug for a year. The other example from the study is something called selection bias due to differential loss to follow-up, where if losses across the exposure group, so across the drugs, are different with respect to the outcome, then selection bias is going to be introduced. So, I mean, you can just see here that the censoring reasons, we already kind of touched on this, but the treatment discontinuation was pretty high across all drugs. But, you know, in this case, it was a little bit higher for liraglutide. So it's possible that the people who remain in the study, you know, are more likely to have the outcome. But they did try to address this by doing the attention to treat analysis, where they just looked at 2 years without censoring for treatment discontinuation. And they found a similar result. So I thought that was good that they thought about that source of bias and tried to address it in their sensitivity analysis. Okay, so that is selection bias. I'm going to move on to information bias, which is a little bit easier to explain. Information bias is simply just error that arises from measuring things, so measuring exposures, outcomes, and variables. And the error from measurement can either be non-differential, where it affects both groups in the same way. A good example is just using OHIP codes to measure exposures or outcomes. Often the misclassification is similar in both groups. Where it could be differential is using administrative codes from hospital admissions. That often only captures people who present to hospital. And also, if there are people who present later to hospital, they might have different codes if they're more sick. So that in that way, it could be differential relating to study groups. So good examples from the study. One of them was exposure misclassification. So this is an example of non-differential information bias because this applied to both drugs, where they considered patients exposed until 60 days after the end of last prescription. And what they did in a sensitivity analysis, they actually varied their window from 60 to 30 days. And so that affects both drugs the same way. They found no difference in their effect. And that was a good way to address potential exposure misclassification. There is a way, however, that it could have been differential in terms of their outcomes. And one of the ways is that in their hospitalization for heart failure outcome, you have to think about who is less likely to present for hospitalization. And, Rebecca did touch on this. So people who are frail and housebound might, be treated for their heart failure, for example, by their family doctor at home. And they might be less likely to have claims data that comes from a hospital admission, for example. Okay, and then lastly, confounding bias. This is when the effect of an exposure on disease is distorted because of an extraneous factors. This is a pretty common source of bias that we think about. The other thing I want to mention is it cannot be you cannot control for something that's a mediator in a causal path. So all that means is that you want this situation where a confounder causes both the exposure and the outcome, but it doesn't directly lead from the exposure and the outcome. So it's associated with both, but it doesn't directly lead to between one and the other. So like a good example of this is like if you break your hip and you end up in hospital and then you get delirium and then you end up going to long-term care and you did a study on that, you can't adjust for delirium because that is a mediator. That wasn't something that affected patient severity before the exposure. It's actually a mediator in the causal path. Okay, and then a good example from today's study related to unmeasured confounding was actually this issue of hemoglobin A1C. So they didn't actually measure hemoglobin A1C level, which is an important reason to get a drug and might affect which drug is chosen. Plus, it could increase your risk of having cardiovascular disease if it's higher. So that's an important unmeasured confounder, and they did think about it, and they actually did something called a quantitative bias analysis, which is great to see, where they looked at a scenario of let's say we threw in hemoglobin A1C and it had a strong association with our outcome. What would happen to our effect estimate? And the effect estimate did get closer to the null, which is 1. You can see that it did in this graph, it did get closer to 1, but it didn't reverse, the association, and it didn't change the direction, and it didn't really essentially produce estimates that were fairly consistent. So even in the presence of a strong unmeasured confounder, they felt that their conclusions were robust. Okay, so that's bias. Moving on to multiple testing. Multiple testing is essentially just when many questions are asked of the same data. Some of those questions will be positive by chance. This is a pretty kind of easy thing to conceptualize. So essentially if you have a p-value of 0.05, 1 out of 20 times, it's going to be positive by chance. So look at this headline. People who walk their dogs are 78% more likely to contract COVID-19, new study finds. Do we actually believe that? I'm not sure I do. When I looked at the study, of course, it was a survey that looked at over 40 risk factors and how they were associated with COVID. And they found that the following significantly increased COVID risk: living with a COVID patient, smoking, using public transport, walking with pets, and working outside the home. Which of these following does not make sense? Obviously, walking with pets. And again, just a good example is if you test enough associations, some of those will be positive by chance. The other thing to be aware of with observational studies using big data is that the design of the study is often intertwined with the analysis, and this can lead to p-hacking and p-harking. P-harking is when you interpret the results, and because you know the results already, you end up generating a hypothesis, which often leads to failure to control for bias. P-hacking is when, actually, I'm just going to talk about how Rubin describes it. So he's an epidemiologist from Harvard, and he said, p-hacking is when the outcome is always in sight. The researcher is faced with a subtle temptation to continually modify the model until the desired association or p-value has been achieved. So it's just like, you know what your p-value is, and you slightly add or take away things from the model to make it positive. The best practices for analysis here are that your protocols should be transparent, pre-specified, and fixed. And this is why if you do like any research at ICS, for example, you have to have a data collection plan where you specify and you fix your plan, and then you stick to that plan. You can't change it along the way. And for that reason, there's also an increased publication of protocols for observational studies now. And I think some of the critical appraisal should look to see whether this was done. Okay, and so other critical appraisal questions to ask, do these therapies have similar clinical indications and risks? That's a good question to ask. In the case of the diabetes drugs, they do. But in the case of cardiac catheterization versus medical management, those potentially are different. And the more different the two therapies are, the more likely there's going to be unmeasured confounding that kind of creeps in to change the association. So that's an important question to ask. The other question to ask is always, what is the magnitude of the effect estimate? Because that depends, or that changes how much you believe it. I'm actually going to give an example from one of my own studies. And I don't know if Dr. Nagli is actually on the call, but he certainly did not believe this association when I brought it up at CGS as a med student many years ago. But essentially what this is showing is that every time you add an additional physician to care, it increases your anticholinergic risk score. And you can see that in long-term care, like, yes, it's a significant association, but that effect estimate is very close to 1. It's very close to the null, and it's more likely that there's going to be an unmeasured confounder that will make that null or reverse this association. So that is an important thing to ask yourself. What is the magnitude of the effect? And then, do the results have face validity? And for example, in today's study, they said that a lot of what they found was actually consistent with clinical trials. So for example, finding that there was more benefit in cardiorenal disease, in renal disease. That's been found in clinical trials. And then the language in the conclusion is also really important. And an example, I'll bring back the example of the NSAIDs in Alzheimer's disease, where if this is a meta-analysis of observational studies, their conclusion was use of NSAIDs lowers the risk of developing Alzheimer's. And it's really important in observational studies that we do not use language like this. It should have said something like use of NSAIDs is associated with a decreased risk, because that's pretty strong language. Okay, just a couple of points on propensity score methods. Propensity scores are balancing scores. What this means is that historically, right, when you use regression, you rely on regression to account for differences in the measured baseline characteristics between groups, right? You adjust for them. Whereas with a balancing score, the distribution of observed baseline covariates are going to be similar because they've been, the balancing score has been applied. So anytime there's a propensity score, you should always look at the degree of the overlap in the distribution of baseline covariates before the balancing score is applied and afterwards. And so I'll just bring up an example from today's study where you can see that before the balancing score was applied, in the sitagliptin group, they were clearly much older. The group was much older, and the standardized difference is almost 0.4, which is not great. And after applying the balancing score, the ages are now very similar, and the standardized mean difference is 0.002, so almost 0. And so that's an important thing to always look at when we're appraising these studies, to look at to make sure they achieved acceptable balance. And because of this, like achieving balance before moving on to the analysis, this is what makes propensity score methods so appealing, is that they allow for the separation of study design from the analysis. Because first you have to construct the propensity score and balance the measured baseline covariates before you progress to estimating the effect of the treatment. And this can be done in various ways that I'm not going to get into right now. Today's study is matching. Often studies will use something called weighting. And another important point to make is that propensity scores are no more likely to remove bias due to unmeasured confounding. because you can't balance something that you can't measure. So that is a very important point to make too. Okay, so now we're going to just test our knowledge. So which of the following systematic biases in observational studies is most difficult to address through statistical analysis? A, information bias, B, selection bias, C, confounding bias, or D, misclassification bias. Please answer in the chat, or maybe someone can answer if they want. Okay, I'm not, sorry, I'm just noticing it's almost 9, so we're just going to say it is selection bias. Remember, selection bias is always baked into the study design. So, you know, you can do sensitivity analyses and quantitative bias stuff for the other sources of bias, but selection bias is really difficult to address through statistical analysis. And then finally, which of the following is true about propensity score methods? Do they randomly allocate individuals into treated and untreated groups? No, that's randomized control trials. Do they balance both measured and unmeasured confounders? No, we just found out that they can't balance unmeasured confounders. Can they analyze data when there's substantial differences in baseline covariates? No, because there's got to be balance before you can analyze data. And then D, do they mimic RCTs by separating the study design from the analysis? Yes, that is what they do. Okay. That is, so there's 3 key points to remember. Observational studies are necessary. They generate hypotheses. They help us evaluate interventions in real world settings. Make sure that when you critically appraise them, you're considering selection, information, and confounding bias. And you might even want to have like slides on each of these things in the future when you look at the bias. Remember that good study design always trumps analysis, and beware of multiple testing. Okay, thanks for listening. I'll take questions now. I'm sorry that we only have 2 minutes.
No, that's great. Thank you very much, Christina, for that great review. I, for one, will be reviewing your slides again to consolidate that knowledge. So thank you for sharing the presentation with us. Go ahead, Michael. You're still on mute.
So a wonderful presentation, and very important to remind us, especially in view of what Sackett's comment was, without observational studies, we would still all be smoking, we would be drinking lead-infested water, and we would be swimming in swamps. Anyway, we know by this time that observational studies are crucial to generating hypotheses. Can you imagine a randomized controlled trial with smoking? I mean, what do? You give out free cigarettes to some group? And anyway, thank you very much.
No problem. Thanks for that.
And some comments in the chat box as well. Jenny says that was amazing, Christina. Barry, thank you. Awesome presentation by both. And Carolyn says, learned about many things that I should have commented on in my last journal club. And another thank you for from Elam. So that brings us to 9 o'clock, unless there are other comments or questions. The evaluation link for this morning's journal club has been distributed to your email. Please take the time to complete it. And again, we thank both Rebecca and Christina for a great way to start our Friday. And have a great weekend, everyone. Thank you.